Now, coming to childhood leukemias, about 40 to 50% of the tumors that we diagnose are actually childhood leukemias. There are two main groups of leukemias, ALL, acute lymphoblastic leukemia, and acute myeloid leukemia. The risk factors for children developing leukemias are completely different. There could be an underlying predisposing genetic conditions, which would be a trisomy 21, like a child with Down syndrome is almost 10 times more predisposed to getting a type of leukemia called AML. Even other syndromes like Fanconi anemia, where the child comes with short stature and also has limb abnormalities, they can develop some cancers. Children with neurofibromatosis type 1, where you have a lot of cafe au laits, where you have a lot of neurofibromas, these children are also predisposed to developing cancers later on in their life. There are some environmental factors have also been listed, of which ionizing radiation, so X-rays, unnecessary X-rays, CT scans, could sometimes actually amount and increase your risk of developing cancers. The other likely factor is pesticides. Now, why does this happen in children? Like, for example, in adults, we often say that drinking, smoking, all of these high risk lifestyle factors could lead to such diseases, but children don't have any of those high risk factors. Why do they still develop cancer? So this is something called as the Knutson's hypothesis. That is the two hit hypothesis. The first step is the initiating event. So a child is actually born with certain mutations, either in their tumor suppressor gene or their proto-oncogenes, which predisposes them to developing cancer when there is a second hit that comes. Now that second hit could be another spontaneous mutation, or it could be some viral infections or some of those environmental or genetic factors that we discussed. Now, what is different? Now, I kept saying, childhood cancers are completely different from adult cancer. So, what is the difference? Now, childhood cancers across the board, whether you're sitting in USA, you're sitting in India, you're sitting in Hawaii, it is the same. So if you remember that pie chart, the most common cancer is leukemia, followed by brain tumor, followed by other solid organ tumors. Whereas in adults, this will change. In our subcontinent, because of tobacco chewing, oral cancers are really, really common. Similarly, if you go to Japan, they eat a lot of smoked fish, smoked meat, and there you will see gastric cancers. You might see colon cancers happening more often. So this is essentially, there is a geographical variation in adult cancers, which does not happen with childhood cancers. Also, in children, the most common site to get cancers are tissues, hematopoietic stem cell tissues. Whereas in an adult cancer, it will generally be solid organ, whether it is prostate, whether it is breast, cervix, uterus, so on and so forth. This is because childhood cancers, they mostly involve the neuroectodermal cells or the mesodermal cells, whereas the adult cancers comes from the epithelial cells. Childhood cancers, we generally catch them when almost most of the cases would be disseminated, but adult cancers, because of surveillance, gets picked up sooner. Now, these were all bad things. It was all against childhood cancers. And if you remember, I told you that childhood cancers actually do well. So, what is in our favor? That children tolerate chemotherapy way, way, way better than adults. You might think a child may not be able to tolerate the cytotoxic chemotherapy, but actually, because their cells are naive, they're still learning, their immune system is still developing, they eliminate cytotoxic chemotherapy way better than adults. Hence, their response to treatment is really good as compared to an adult's. Now, childhood cancers, like I said, are often incidentally detected. Mother was bathing the child, suddenly found an abdominal mass. You were clicking a picture and suddenly you see a red eye or a white eye in the photo. So all of these are incidentally detected, and hence by the time we detect, they're most often metastatic. And there are no risk factors for developing childhood cancers like in adults, and hence the opportunity for surveillance is less as compared to an adult cancer. For cervix, you would advise for pap smear. For breast, you say breast examination. For prostate, you would do all of these tumor markers. But in childhood cancers, we don't have anything like that. Hence, suspicion is key. Now, why did I decide to take this topic on a whim? Is because I think when we have such a big, august audience, yes, you should learn the most common things. But in the back of your head, when you come to a place like SRCC, you should also probably pick up a few things that are uncommon. Because early detection can change the life of these children. September is actually Childhood Cancer Awareness Month, and hence we thought that let's just talk 5 minutes on childhood cancers and try to educate ourselves. Because the symptoms of childhood cancer is like anything else. This child might just have a fever, they might just have a lump that is not going away, they might have a headache that you can't explain, a visual disturbance. All of this, when you can't make sense, referral and further investigation and not going on in the same loop is essential, because childhood cancers can be at play. Now, common signs and symptoms, like I said, with blood cancers would be fever, persistent lymphadenopathy, anemia, bleeding diathesis. There could be a silent abdominal mass, just hepatosplenomegaly with abdominal distension. When it's a brain tumor, they can have a change in gait, they could have a change in visual disturbance, or a white eye reflex when it is a retinoblastoma. Uncommon signs and symptoms, unlike in adult, would be an unexplained weight loss, bone pains that are more in the night, or some paraneoplastic syndromes. But again, this is very, very uncommon in children. So when you click a photo, you would have clicked your own photo, right? And then because there is no tumor sitting at the back, hence your retina just sort of pushes the light back and you can see your eyes clearly in the picture. A white eye is when you're trying to click, when you flash and you actually see in between the eye, there is a white eye. You cannot see the iris clearly. So that means there is something that is blocking this retina. And that most often in children is an eye tumor called retinoblastoma. Hence, when you're getting a white eye, you should definitely meet an ophthalmologist, do a fundus examination, if not an examination under anesthesia. Now, retinoblastoma is very, very uncommon in the Western world because all the children are on follow up at 1 month, at 3 months, at 6 months. They even have some apps on the phone where the parents pick up retinoblastoma even when it's a small tumor by just clicking the photo. Whereas with us, our knowledge and awareness, yes, is slowly increasing. But by the time they come to us, they come with a widely metastatic, which then becomes incurable. Now, coming back to leukemias, most common childhood malignancy is the lymphoblastic leukemia. Most common presentation would be fever, bleeding, bone pains, abdominal distension, splenomegaly, just a splenomegaly, or just a lymphadenopathy. This is how we diagnose leukemias. The easiest thing that can be done is when we ask for a CBC, also ask for a peripheral smear. And if the counts are high, you will definitely see these abnormal monomorphic cells where the nucleus is large, and these are nothing but lymphoblasts. Closely on the heels of it, having worked quite a few years in this field, these children are often misdiagnosed as arthritis, juvenile idiopathic arthritis, immune thrombocytopenia, which is common, or infectious mononucleosis. No child will come with leukemia written on forehead. There is an amount of suspicion that is needed, and these would be the common misdiagnoses these children come with. The treatment, really, like I was telling you, yes, has gone a massive change, but there have been no new drugs that have come in. In the last few years, the new development that has taken place is immunotherapy, which is more common in adults than in children. But we now have immunotherapy, sort of an immunotherapy even for leukemias. But the drugs have all been what we've been using for decades now. There are two phases of treatment: intensive phase, where we try to put the child in remission, which can last anywhere between 6 to 8 months. And then there is a maintenance phase in ALL, which lasts for about a period of 2 years. So what do we need to know? The diagnosis can be second, but the first thing is stabilize this child. If he's bleeding, look at the platelet count, try to stabilize the platelet count, a bit of transfusion. But one thing we need to know is sometimes even a bit of transfusion can put a child in temporary remission, and we may lose that window of diagnosis. Hence, involving a pediatric hematologist and oncologist at the first thought of suspicion is quite important, because if you miss the window, then we may not be able to appropriately treat him. The other thing we take care of are complications during treatment. Like I told you, the outcome has changed from 4% to 94%, and it is mainly because of the supportive care we give these children. So being aware of something called as tumor lysis syndrome, which can be catastrophic with end-stage renal failure. Hence, hydration, drugs like allopurinol, all of this is essential, and frequent blood monitoring. Now, like I said, the ALL maintenance phase is to prevent a relapse, and this could be anywhere between 2 to 3 years, depending on what protocol we use. Now, the complications that we often see, and where there is a huge role for primary care physicians, is management of febrile neutropenia. So, febrile neutropenia is nothing but just like sepsis, where we have the golden hour. In febrile neutropenia, also this golden hour exists, where if the child is neutropenic, comes with fever, even before we do anything, a cannula, blood culture, and antibiotics is must. You don't discount any fever as viral fever for a child who is on chemotherapy. And this can actually save the life of this child. And suppose the child is living far away. So the first point of contact should be the primary care physician rather than coming to a hospital where they're getting treated. Hence, this communication between the treating specialist and the primary care physician is very, very essential. So in an ideal world, something that we should definitely look forward to is working in a shared care approach, where nobody is losing the child. The child first goes to the primary care physician. The primary care physician, at the first point of suspicion, gets in touch with the specialist, and then there is a communication that opens up. For anything that is non-life threatening, it should be done closer to home with the primary care physician. But complicated things like chemotherapy, where monitoring is needed, or maybe ICU setup is needed, they come back to a tertiary center like ours. Now, the most common infections we would see are bacterial, and hence, at the first fever spike, within half an hour, we try to give the antibiotics which are appropriate. Now, just to further that thought of 4 to 94% jump, it is because we are able to adhere to these protocols, and thereby all the treatment-related mortality has come down every decade. Again, immunization is something that can be with the primary care physician. So children, even if they're immunized prior to treatment, again need their boosters after about 6 months of completing their chemotherapy. Again, we drop their chart and we send them back to their primary care physicians, where they can revaccinate their children. The story doesn't end after we give the last chemotherapy. Given all of the drugs that we give, they're actually predisposed to getting some late effects. So we follow them up in their after completion of therapy clinics, where some drugs can lead to cardiotoxicity, so you monitor for that. Some drugs can lead to growth abnormalities. Radiation can lead to growth abnormalities, for which we keep them on regular follow-up, and hence you're not catching them once that complication has developed, you're catching them early. Encouragement of healthy lifestyle, all of this is looked at in the ACT clinics. So what we essentially need to know is childhood cancer is curable. Role of pediatrician is or primary care physician is extremely integral in management of these children. If we want to show that jump of 4 to 94%, early diagnosis and prompt referral is key. Recognition of pediatric oncological emergencies, initiation of the management at their first point of contact. And again, during maintenance chemotherapy, you work in a shared care model so that you're not displacing the child or troubling the family too much. I think I'll end my talk here. Thank you. Are there any questions?
Stage 1 that can be
stage 1? So basically, leukemias, there are no stages because blood is everywhere. The only two places where we look at for metastasis is the CSF, and in boys, you look at testes. So whatever the stage, we don't go by stage in pediatric leukemias, we go by cytogenetics, we go by molecular reports. All cancers in children are treatable. How much will depend on actual risk stratification. So AML across the board is about 50 to 60% outcome. It is 50 to 60 with good cytogenetics, but with some adverse molecular markers, this could be a little lesser. But on the other hand, ALL is about 90 to 95%. In fact, US claims 100%. A center in US called St. Jude claims 100% survival for their children with ALL. All right, so I'm going to stop my talk here, and I'd like to invite Dr. Priti, who's our senior consultant, again in the same department, Pediatric Hematology and Oncology. Dr. Priti has a wealth of experience in managing various hematological and oncological disorders in children, and also taking them till the end by doing something called as bone marrow transplant. You will be talking about ABC of CBC, something that's very, very relevant to our practice. Thank you.
So good afternoon, everybody. I know it's post-lunch. I hope I can keep you awake throughout the session. A nice talk by Priti, and thanks for the warm introduction. I also do bone marrow transplants, but today we will stick to the basics of ABC of CBC, which is very, very important in our day-to-day practice. Every physician's practice starts with CBC. So should I start? So we need to put in the slide sharing. It's already there. You can see the slides on the side. Yeah, fine. So I start with the basics of ABC of CBC. So we know that we have these automated cell counters. And what do these cell counters do? Whenever a cell passes through the cell counters, it gives rise to an electrical impulse, and that gives rise to a certain volume and height and volume of that cell, and that's how the cell counters record the cells, and that's how they categorize them as red blood cells, WBCs, or platelets. And these automated counters are definitely better than manual counters because of the accuracy, with the ease with which we get the reports. But there are certain, but nobody can replace humans, is what I will tell you later. But definitely these automated counters are better than the manual counters. But the laborious things like differential count and all that, the platelets, they should be looked by a physician or by a technician or by a pathologist, which is very, very important. So now, what the limitation of this counter is that standardization is required for these Coulter counters. And secondly, as I told you, the platelet count, you cannot just rely on your automated counters. You also have to look at your WBC differential count, because what comes in your automated report may not be what actually your peripheral smear is showing. Now we know that there are different types of analyzers, parts 3, 5, and 6, 7 part analyzers. What do these 3-part analyzers give us is only the neutrophils, lymphocytes, and monocytes. Add eosinophils and basophils, that becomes a 5-part counter. There are now 6-part counters available in certain cities where it is, or in certain labs where the immature granulocytes are also taken into account. And the 7-part also gives you the blasts on the manual counter. So which we normally see with the eyes is given by these automated counters. This is how your CBC is going to look, and this is how you will, these are all the parameters that come in your CBC, and we will go through each one of them with examples. So now when you look at normally when you do a CBC from any lab, they have some normal range values, but that is according to the adult range, and you cannot extrapolate it to the pediatric range because children have different normal values apart from what adults have. So if you look at both, when a baby is born at 1 to 3 days of life, your hemoglobin is as high as 17 to 18 grams, which is normal for a newborn. And the MCV is very high. It is macrocytic. The RBCs are macrocytic. And then slowly the MCV starts going down, the hemoglobin starts dropping down. By 6 to 12 years, the hemoglobin is around 12 to 13, and the MCV has dropped down to 76. Similarly, the retic count is very high in newborns, around 5 to 6%, and it gradually drops down to 1% in by 6 to 12 years. And then as the child is growing, becomes a male or a female, again the hemoglobin increases to 14.5 grams percent. So this is what the normal values are. So if you see a neonate with a high MCV, you know it is a normal value. Now, so what are the common, so how is a neonate different is what I've already told you, so we can skip through this slide. And the retic count is also 3 to 7% at day 1 of life of birth. Then it gradually drops to 2 to 3% on day 3, and then by day 7 onwards, it comes into the normal range. When we talk of the automated counter, the directly measured are the RBC, WBC, platelet, hemoglobin, and retic. You derive from the histograms these MCV, RDW, the platelet distribution width, whereas the calculated ones are the hematocrit, the MCH, and the MCHC. Now a lot of new parameters come in these automated counters. The nucleated red blood cells are also included, reticulocytes, immature retic fraction, red HE content, and fragmented red cells. Many counters give, not all of them. White cell parameters are the immature granulocytes, the blasts, as I told you, and the platelet parameters are the immature platelet fraction. So a few counters give all these reports also. Now let's run through a few cases to make things easier for us. This, and these are the cases which have been referred to me and managed by me. So, an 8-year-old female child born of a non-consanguineous marriage presented with fatigue and exhaustion. There was a decrease in activity progressively since the last 3 months. There was no history of blood loss worms, no history of burning pain in the chest, no previous admissions. A lover of junk food, which most of the children these days are, with a marginal intake of healthy food. On examination, she was pale. There was no hepatosplenomegaly, no lymphadenopathy, and she was hemodynamically stable. And this is how pale she looked. If you can look at the conjunctiva, it's quite pale. Her CBC showed a hemoglobin of 5.6, an MCV of 55, MCH of 13, RBC count of 2 million, RDW was 22.4, WBC of 6,400 with 45% neutrophils and a platelet of 5.5 lakh. Anything that you want to interpret from the CBC? Hemoglobin is low. Platelet count is high. Anything else? 8 years. MCV is low. Correct, sir. Anything else? RBC count is also low. It's only 2 million. So, and if you look at the peripheral smear, you can look at the cells. They are completely like vacuoles. Normally, the RBCs are 2/3 hemoglobinized. These are just like a circle, there's hardly any hemoglobin seen. So how would you try? So this is a case of iron deficiency anemia. Iron deficiency anemia because there is low hemoglobin. There is low MCV, low MCH. So you have a low hemoglobin, you have a hypochromic microcytic picture. That means low MCV, low MCH. The RBC count is also decreased. What is the Menzer index? MCV upon the RBC, and that is increased, which happens in iron deficiency anemia, and your platelet count also increases in iron deficiency anemia. And that is because the thrombopoietin receptor is very close to the erythropoietin receptor. So the marrow is getting stimulated to produce more RBCs. But because there is not enough iron, the RBCs are not being produced, but the platelets are getting produced. So when you see a picture like this, most of the times it is a iron deficiency anemia. And then she was treated with iron supplements and she responded well. The MCV has come up to 80, hemoglobin to 12.8, platelets have normalized to 2.5 lakhs, and this is how she looked, but she had a little pigmentation with the iron that she was given. Now, what if this child did not respond to iron supplements? Though the picture is clinically like a iron deficiency anemia, but she has not responded to the iron supplements. So there is a new entity which has come up, which is known as iron refractory iron deficiency anemia. and that is because of a mutation in the TRMPSS6 gene, which controls the hepcidin. And if that gene is mutated, these children don't respond to oral iron, but only respond to IV iron. So that is the new entity which has come up. So if this girl, big girl, 8-year-old, having iron deficiency anemia, if she's not responding, the next thing I would keep in mind is she having this mutation? Secondly, is she having any blood loss from anywhere? So is there any bleeding from her GI tract? Is she having any fissure, piles, anything else? So all these things need to be kept at the back of the mind. Would you want to transfuse a hemoglobin of 4.5 8-year-old with blood in this child? Would you have given her, she has come to you, she's hemodynamically stable. Would you want to transfuse her a blood? Not to transfuse, because if the child is hemodynamically stable, she will, and that's what we did. She responded beautifully to iron supplements. Now, this is a 8-month-old, born of a second-degree consanguineous marriage. He was referred for evaluation of anemia. He was transfused first time at the age of 2 years and 2 months. So the last 6 months he has been on iron supplements. His hemoglobin was 2.5, MCV was 82, MCH 26, which is not very bad. It's not low. Retic 2.6, WBC count is okay, differential is okay, platelet is 2.5 lakhs, which is also fine. Peripheral smear showed aniso, poilo, spherocytosis, schistocytes, macrocytosis. This child has had febrile convulsions since the age of 9 months. He has been slow in his development. He is standing with support only at 2 years and monosyllables at 2.5 years. And his second convulsion was at the age of 2 years, and he has been on valparin since then. So he has been symptomatic with convulsions since 9 months of age. At 2 years, 2 months, he has low hemoglobin, and he has been started on iron supplements. His hemoglobin was 4.8, MCV 84. This was when he came to me. Again, a similar picture, not much different. He was pale and he had hypotonia. His serum iron studies were completely normal. Retic was 1%, LDH of 482, Billy was 0.4, stool local blood negative. MRI, which was done earlier, did not show anything significant, and EG was normal. So now the pediatrician thought this is valparin-induced anemia, because after introducing valparin at the age of 2 years, his hemoglobin had started dropping. So it was thought, and valparin can cause that. So it was thought that this is and he was shifted to Levera. But however, his hemoglobin continued to be low. The MCV, MCH was not very low. And because he had hypo and micro and macro, they thought it's a dimorphic anemia. They did the folic acid levels, the B12 levels, which were all normal. And then ultimately, I was referred for a bone marrow. It showed a hypercellular marrow. The ME ratio was 2.5. All the cell lines were quite okay in the marrow. There was mild erythroid hypoplasia and dyserythropoiesis. When we did the iron stain, we saw 10% ring sideroblasts. And then it was like whether this is a myelodysplastic syndrome or a refractory anemia. The karyotype was normal. The patient was put on pyridoxine, and we asked for a NGS. The patient refused next generation sequencing and was lost to follow up. This was a bone marrow, and I don't know whether you can appreciate the small rings around the red blood cells. Very difficult, not very clearly seen, but I don't know whether you can appreciate that. I don't have a pointer to show you though. Is it clear? Can you all see the rings? Yeah. So this is the staining. So the ring sideroblasts are basically the erythroid precursors, and they contain deposits of non-heme iron in mitochondria, and they form a ring-like distribution around the nucleus. And then we did his next generation sequencing. The parents ultimately agreed, and it turned out to be a autosomal recessive sideroblastic anemia with myopathy, lactic acidosis, and that's why he was hypotonic. So what this case highlights is when iron studies are normal, think of anemia of chronic disease or sideroblastic anemia, always ask for iron staining of the marrow. The X-linked mutation, normally our teaching is that sideroblastic anemia causes microcytic anemia. But sideroblastic anemia can also come with macrocytosis if it's a mitochondrial DNA defect and not an X-linked variety. So it is not always microcytic. So when a child with microcytosis with a low MCV comes, first of all do a serum ferritin. If the serum ferritin is low, that means we are dealing with deficient stores and it could be iron deficiency. But if the serum ferritin is normal, that means we are dealing with other causes of hypochromic microcytic anemia. And hypochromic microcytic anemia, there are only 5 causes. First is iron deficiency, second is thalassemia trait, third is sideroblastic anemia, fourth is lead poisoning, and fifth is anemia of chronic disease. So these are the 5 causes which cause hypochromic microcytic anemia. So now, when we're looking at the RBC series, you don't just look at the hemoglobin, look at the MCV also. That gives a very clear picture of which way are we going. Is it hypochromic or is it not hypochromic, normochromic, or and then look at the microcytosis or the macrocytosis. So MCV will tell you it's micro, normo, or macrocytic. Look at the RDW and the RBC count. There is always a rule of 3. The RBC count into 3 is the hemoglobin into 3 is the MCV. Now, the MCV in children between 2 to 10 years of age is normally 70 plus age in years. That is the norm. So, whenever a child between 2 to 10 years comes, you can calculate the MCV. And the MCV approximate upper limit for MCV is beyond 1 year of age is 84 plus 0.6 femtoliters per year. So that's how, and the adult range is 96. So anywhere, if your MCV is not between 70 and 96, you should be worried. That means there is something wrong going on in the child. And so next is the red cell distribution width. So you look at the red cell RDW also. If you have any nutritional deficiencies, your RDW will increase. So if you have microcytic anemia with a high RDW, you are dealing with iron deficiency. Or if you have a macrocytic anemia, high MCV with a high RDW, you are dealing with a megaloblastic anemia. Am I clear? Is that clear on, or I can explain you by examples. So first of all, look at the MCV. We have said the 5 causes of a low MCV are the iron deficiency anemia, thal minor, lead poisoning, and sideroblastic anemia. Whereas when you have a high MCV, you are dealing with a B12 folate deficiency, myelodysplastic syndrome, leukemia, hypothyroidism, drugs, aplastic anemia. Now, when a child comes with a high MCV, suppose comes with a MCV of 105, how do you know this is B12 folate, or how do you know this is aplastic anemia? You will look at the RDW. If your RDW, red cell distribution width, is increased, it is telling me it is a nutritional deficiency. So most probably this is a B12 folate deficiency. If my RDW is normal, I'm dealing most probably with an aplastic anemia. So it gives you a rough guide as to which way the child may be going. Let's come to the next one. Next is a 5-year-old child from Gujarati Luana community with no complaints on routine health examination in school, picked up with mild anemia on the CBC. His hemoglobin was 8.6, RBC count of 6 million, MCV 54, MCH 16.7, retic count of 1%, RDW is 14%, and platelet 33.5 lakhs. Anything you can tell me on this CBC? Can you point out something? He's just picked up. He has a low hemoglobin. 8.6 for a 5-year-old is low. And he's healthy otherwise, just picked up on routine school screening. No. Thalassemia. Here you are looking at the hemoglobin. The hemoglobin is 8.6. You have a low MCV, low MCH. And as I told you, when you have a low MCV, low MCH, next you look at your RBC count. Is your RBC count normal or high or low? It's high. Normally, yeah. So when RBC, so you've ruled out iron deficiency in this child. Because if it's iron deficiency, you would have had a low RBC count. Your RBC count is high. So I can tell you that this child most probably has a thalassemia, and he has not presented till 5 years. So this could be a thalassemia trait. And so the peripheral smear is what, and the hemoglobin electrophoresis in a thal trait will show an increased HbA2. And that is what exactly happened in this child. So there is a hypochromic microcytic picture. The RBC count has increased, the RDW is normal, and the Menzer index is less than 13, and that's how we diagnose thalassemia minor. So this is how you will look at an iron deficiency versus a thal minor. So RBC count will be low in an iron deficiency, high in a thal minor. The Menzer index, that is the MCV upon the RBC, will be high in iron deficiency, low in thal minor. RDW is high in iron deficiency, whereas normal in thal minor. Ferritin is low in iron deficiency, normal. HbA2 will be high in thal minor, and a response to iron trial iron will be good with iron deficiency, but not with thal minor. So this child does not need to go on iron supplements. If somebody would have just looked at the hemoglobin and said low MCV, low MCH, just give iron supplements, this child will not respond. Just last week, I saw a 14-year-old like that who has been having this picture since the first time his CBC is done, and nobody has done his hemoglobin electrophoresis, and he's turned out to be a thal minor. And it's very important because that's how we are going to prevent future thal majors in the society. Because if he gets, unfortunately, if he gets married to a spouse with thal minor, we are giving a birth to a thal major. The 7-month-old male child, Hindu Maratha community, non-consanguineous marriage, brought with fever, cough, breathlessness, failure to thrive, pallor, irritability, and listlessness, has a cardiac failure with right mid-zone pneumonia, grade 4 PEM, and moderate form hepatosplenomegaly. Hemoglobin is 2, MCV of 65, total count is 32,000, RDW is 13.9, and neutrophils are low. So if you look, hemoglobin is low, your total counts are high, but your neutrophils are low, and the peripheral smear is showing nucleated red blood cells. So what are these nucleated red blood cells? These are the immature RBCs which have nucleus in them, which are counted as RBCs. And they get counted as WBCs. And because they get counted as WBCs by the Coulter, you get a high high WBC count. When the WBC count is not high, actually. Are you getting me? So these NRs, nucleated red blood cells, are counted as WBCs, and because of which this child had a high WBC of 32,000. And this picture of low hemoglobin, low MCV, low MCH, this is a classical thal major picture. Where you get a high WBC count, you are seeing a lot of nucleated red blood cells in the peripheral smear. And so these are the precursors of the peripheral blood cells. They are seen in only, physiologically, you can see only in neonates and premature babies. And then they get erroneously counted as WBCs. And so this child's hemoglobin electrophoresis showed a hemoglobin F pattern. And so this was a case of beta thal homozygous. So thalassemia major. So whenever you have a high WBC, you have to correct the WBC count whenever the nucleated red blood cells are more than 5 per 100. And this is how you correct. This is the formula, WBC into 100 upon the nucleated red blood cell plus 100. And so the corrected WBC is 26,000 for this baby. Am I clear? I have actually a lot to cover and it's a long topic. So I will have to rush through because the other speakers are also waiting. So the retic count also needs to be corrected. And so the retic count is the retic, how do you correct the retic count? Retic into the hematocrit divided by the expected hematocrit. So whenever you get a hemolytic picture and you have a high retic count, with a low with a low hemoglobin, always correct your retic count. And this is the formula for correcting the retic count. Nowadays, certain Coulters give you the RET HE, and it identifies iron deficiency anemia earlier than the traditional parameters. So if you see a RET HE which is increased, it's a direct measurement of the incorporation of iron into the erythrocyte hemoglobin, and it tells you whether there is iron deficiency or not. Immature retic fraction, just as you do immature platelet fraction in dengue, there is also an immature retic fraction where if your marrow has started producing, the retic count, the immature retic fraction is higher. Now, there are some fallacies of the hemoglobin electrophoresis. When you are interpreting the hemoglobin electrophoresis, you have to ensure that the child does not have iron deficiency or megaloblastic anemia. Otherwise, you may not get the correct report. Are you getting me? The hemoglobin A2, which increases in thal trait, may not be correct if the child has an underlying iron deficiency or megaloblastic anemia. So ensure that the child does not have any iron deficiency or megaloblastic anemia. Next, we come to a 5-month-old female bought with history of watery greenish stools 5 to 6 times per day, failure to thrive. Baby was exclusively breastfed and mother was a vegetarian. On examination, there was pallor, knuckle hyperpigmentation, grade 4 PEM, no hepatosplenomegaly or any other significant findings. The hemoglobin of 5.5, MCV was 100, MCH of 31.3, total count is 6,200, but the neutrophils are only 10. So absolute neutrophil count is only 620 and platelets of 1 lakh. So you have all three cell lines which are low. Hemoglobin is low, your absolute neutrophil count is low, though your WBC count is normal, and your platelets are low. So any diagnosis, can you all say what this could be? Megaloblastic anemia, absolutely, sir. So this is what you will see. You will see hypersegmented neutrophils, large RBCs, and this is a case of megaloblastic anemia. LDH was sky high, B12 was low. Child was being breastfed, mother's B12 was also low, so was treated with B12 injections. If your B12 and RBC folate levels come normal, it does not rule out megaloblastic anemia. It can still be megaloblastic anemia, and you should do the MMA levels because B12 acts as a cofactor in converting MMA to succinyl coenzyme A and homocysteine to methionine. So that's why at times, if your B12 and folate levels are normal, you should do the MMA levels in these children. Yeah. So megaloblastic anemia begins with the RBC series and then gradually it affects all the cell lines. So you can get pancytopenia with megaloblastic anemia also. So should I continue or continue? A child has severe pallor with mild splenomegaly requires transfusion. The CBC is showing an unusually high MCV of 150 and deranged other RBC indices. What does the high MCV in this scenario suggest? And what needs to be done to further establish the diagnosis? I'll tell you, when you have a very high MC of more than 50, the report is wrong. Don't rely on that report. Repeat it from another lab. Okay, so don't get worried. The child is all right. So get it repeated from very high MCV is usually erroneous. 7.5-year-old female brought with developing reddish spots all over the body, bleeding gums, melena, high-grade fever since the last 2 days, pallor, petechiae on upper limb, chest wall, no lymphadenopathy, no bony tenderness or hepatosplenomegaly. Hemoglobin of 7.5, MCV is 98, MCH 30, RDW is 13.7, which is in the normal range, right? Total count of 4,400, neutrophils are 10. So absolute neutrophil count is only 440, platelets are 35,000. PS is showing few macrocytes, neutropenia, platelets diminished. So if you see all three cell lines are low, the child is 7.5 years old, hemoglobin of 7.5, your MCV is on the higher side, so it's a macrocytic picture. Your RDW is normal. ITP will not have a low hemoglobin, will not have a decreased WBC count. You have to look at your ANC. Absolute neutrophil count is 440. So your all cell lines are low. In ITP only your platelet count will be low. Aplastic anemia, absolutely. So when you saw a picture of megaloblastic anemia with pancytopenia, but you look at the MCV of this child. The MCV of this child is, look at the RDW, 21.4, it's increased. Red cell distribution width. So what happens in megaloblastic anemia? In aplastic anemia, your marrow is not working, but it is producing cells of the same type. That's why your red cell distribution width is not increased. It's in the normal range. But in megaloblastic anemia, depending on the B12 or the folate supplement that the child is taking orally, your cells are large, but the RDW, so they are not of the same size. Are you getting me? So your RDW is increased. And that's why in nutritional deficiencies, iron deficiency or megaloblastic anemia, RDW will be wide. In iron deficiency, you will have microcytosis with a high RDW. In megaloblastic, you will have macrocytosis with a high RDW. But in aplastic, you will not have a high RDW. And in thalassemia also, you will not have a high RDW. That's now on your examination, on your periphery, on your CBC. If you see a low MCV, low MCH, and a normal RDW, think of thal minor, and the RBC count will be high in a thal minor. The RBC count will be low in a iron deficiency. In a megaloblastic, if you're having macrocytosis with a high RDW, it is a nutritional and it is a megaloblastic anemia. But if the RDW is normal with a pancytopenia and macrocytosis, it is an aplastic anemia. This will give you a rough guide in your clinic. Am I clear? Yeah. So this is a child of, see, look at these all fat spaces. There is no cellularity and it is fat spaces. I think I'm exceeding my time. So this is the algorithm for macrocytic anemia. If a child has macrocytosis with a low hemoglobin, rule out is the child on hydroxyurea, any other drugs. Next, you rule out B12 folate deficiency and look at the B12 and the homocysteine levels. These are the common causes of pancytopenia, a lot of causes. So now I No, there are many speakers, no? So, okay, approach to a normochromic normocytic anemia, look at the retic count. If the retic count is increased, it talks of hemolytic anemia or a post-hemorrhagic anemia. And if it is normal or decreased, then you have to do a bone marrow examination. We know the different types of white blood cells. And then we know about the neutrophils. So you can have neutrophil defects which can be qualitative or quantitative. This is a 9-month-old with high-grade fever since 8 to 10 days. No obvious focus. Hemoglobin, there is on examination nothing significant. Hemoglobin of 10.5, WBC is 52,000, 38% neutrophils, 55% lymphocytes, platelets of 230,000. Anything that's coming to your mind? So there is a WBC which is high, right? 9-month-old. Hemoglobin is not so bad, platelets are not so bad. It's only the WBC. Could this be an infection?
No.
No? Why, sir?
Lymphocyte count also
Can be a viral infection.
it won't, and WBC will be 52,000.
Yes, so it can be a leukoid reaction. It can be a leukoid reaction. So it can be an infection because of a leukoid reaction, or it can be malignancy. Not every malignancy has to have a liver and spleen. Acute myeloid leukemias usually don't come with a liver and spleen, but your platelets are low. But I have seen at times, very rarely, even with a normal CBC, a leukemia coming in. Though the hemoglobin is 10.5 and the platelets are 2.5 lakhs. So very, but keep it at the back of your mind. Third is leukocyte adhesion deficiency. So this child is how old? 9 months. It's an infant. Leukocyte adhesion deficiency is where your neutrophils are normal in number, but their function is not correct. And because of it, these children have very high WBC counts. And they have a neutrophilic predominance. Are you getting me? So that is also possible. And the fourth thing is this could be a thalassemia. Because as I showed you, that the nucleated red blood cells are not as counted as WBCs by the Coulter. So unless somebody sees a peripheral smear and says that these are nucleated red blood cells, could this be a thalassemia presenting at 9 months, thal major presenting at 9 months of age? So these are the differentials that I can keep at the back of my mind. Am I clear? Is there any doubt, sir? Anybody has any doubt? No. So whenever there is a shift to the left, we know that this happens. You get the promyelocytes, myelocytes. So leukocyte, what is leukocyte reaction? In infants and children, there is a tendency to release the immature granulocytes in the circulation. And so the WBC count goes very high. It is often associated with bacterial infections. And you will see a 5% shift in the percentage of the immature precursors bands due to rapid release of the bone marrow reserve. And that's how they present with leukocyte reaction. When you are in your OPD, no, when you see the WBC count, always make it a point to look at the neutrophils and calculate the absolute neutrophil count. So in your WBC, in your CBC, they will tell you that out of 100 WBCs, there are 10 neutrophils. That means your absolute neutrophil count becomes just 10 into 100. Sorry, 10 into, so out of your WBC is suppose 3000 and you have in your differential it gives you 10. So what is my absolute neutrophil count? So out of 100 I have 10 neutrophils. So out of 3000 how many do I have? Got it? So that is just 300. So always calculate that, because between up to 1 year of age an absolute neutrophil count less than 1000 is significant, and in beyond 1 year of age if it is less than 1500, that means there is something going wrong with this child. So when you look at your WBC count, always look at your neutrophil count as well. This is very long. Similarly, in look at the lymphocytes. In the first year, the children are lymphoid organs, so they have more of lymphocytes. But the absolute lymphocyte count at birth is less than 2000. By 9 months, less than 4500, and less than 1000 in older children and adults. You have to suspect some problem. Now, what are the causes of lymphocytosis and all that is, again, the eosinophilia we all come across. If it is more than 1500, it is significant. I will just take you to platelets less than 1.5 lakhs is suggestive of thrombocytopenia. Whenever you see a child with decreased platelets, ask the technician to look at the peripheral smear, because there may be a clotting of the coagulation of the platelets because of the in vitro clotting due to the EDTA. and so it becomes a clump, and then they don't get counted as platelets, and that's why you get a false platelet count, and that's why you should repeat with a citrate or heparin as an anticoagulant. Am I clear, or am I going too fast? Yeah. So there may be something like a pseudothrombocytopenia. So, uh, there are two parameters as far the platelets are concerned. One is the mean platelet volume, and second is the immature platelet fraction. Very, very important pertinent. Mean platelet volume is normally 7 to 11. If it is high, that means there is a rapid cell turnover. And that's why in dengue, most of you do the IPA, the look at the mean platelet volume. So whenever the mean platelet volume is high, it is suggesting that there is a rapid turnover of the platelets, like in ITP or thrombotic thrombocytopenic purpura, or in Bernard-Solier syndrome or the May-Heglin anomaly, the MYH9 related disorders, which are the congenital disorders. But when the mean platelet volume is low and the child is presenting with bleeding, there are only two causes which are very, very, one is viscous alteration and second is X-linked thrombocytopenia. So always make it a point to look at the CBC completely. If a child is presenting with bleeding, has low platelets, look at the mean platelet volume. If the mean platelet volume is less than 7, you may be dealing a child with Viscott-Aldrich syndrome or with X-linked thrombocytopenia. And immature platelet fraction is what you do in dengue. You look at the immature platelet fraction. So the immature platelet fraction, if I have a platelet low and I look at the IPF and my IPF is a high, the IPF normally rises 2 days before your platelet count starts rising. So if my platelet is low and my IPF is low, that means this child is not going to produce platelets and then I need to transfuse. But if my platelet is low but my IPF is high, that means the marrow is pushing and over time it will start after 2 days, it will start producing the platelets. So when to worry about bleeding, if the platelets are less than 20,000, there are mucosal bleeds. In surgical cases, you may want to keep it above 50 and in major surgeries above 1 lakh. So I will skip this case and I come to the end of my talk. So CBC is beyond hemoglobin, WBC and platelets. You need to look at the MCV, MCH, RDW, RBC count, retic count, everything. WBC differential count with peripheral smear examination is a must. Always calculate the absolute neutrophil count. If less than 1,500, it's a red flag. Absolute lymphocyte count is also very important. Never prescribe steroids even for eosinophilia because you may be masking an underlying eosinophilic malignancy. And in thrombocytopenia, history is a must. Clinical examination a very must. Peripheral smear evaluation is a very must to rule out pseudothrombocytopenia because of the EDTA-induced platelet clumping. Steroids are a big no-no for everything. Unless you are very clear as to what you are dealing with, don't please prescribe steroids. And then we can help you out if any help is required. Thank you so much. I'm sorry I had to rush because it's a huge topic to be covered in 20 minutes. Any questions?
Yeah, anybody? You can also ask your questions at the end of the session.
So next is Priya Pradhan. She is our pediatric cardiologist who will be talking to you about the basics of pediatric cardiology.
Everybody. I just wanted to know because so how often do you see children here in like can you raise hand? Okay, pediatricians exactly. So I will just try to be more pertinent to because even as general physicians, we are also family advisors. So you might also people must be asking you for advice even though they are seeing pediatricians. So we will just cover a little bit more so that when you go out from here, you will be more confident in dealing with children with congenital heart disease. So I just want to tell you what is happening in today's day and age, how are we diagnosing, and where are we missing out, and how you guys can help in this scenario. Yeah. So, do you all use pulse oximeter in your OPDs?
Ma'am, can you unmute yourself, please?
Hello, ma'am. Can you please unmute? We can't hear anything.
I'm so sorry for this technical glitch. Yeah, sure.
And the in saturation,
Yeah.
the difference would allow for
At least 5. Yeah, so again, it has to be optimal situation. So usually what happens is the lower limbs are cold. So you have to really warm the limbs up before you start taking saturations. All the peripheries have to be nicely warm, and difference of even 5 should be taken as something significant, and then you have to send the patient for an echo. So definitely. So you should the probe and the blood pressure curve, both of them should be of appropriate size. So adult pulse oximeter does not pick up the, because the limbs are very small. There's a lot of light going on both the sides, and you will not get correct reading. So you should have a pediatric. In fact, for the NIC patients, you should have a neonatal BP cuff as well as a neonatal pulse oximeter. Sometimes they are like a band, or sometimes even the clips. So let me not go into the different scenarios. I have various scenarios where I would have given you clues of how you can diagnose. So suppose if the saturation is less than 90 degrees, okay, 90%. I'm so sorry. So any saturation less than 90% is cyanotic heart disease. Okay. Now if you have all the 4 limbs of low saturation, means mixing is happening inside the heart. So it is not at the PDA level because all the 4 limbs have the same saturation. So left ventricle is only pumping out blood, which is having less saturation. So in that case, you have lesions like TAPVC, that is total anomalous pulmonary venous connection, wherein the pulmonary veins only are coming and draining into the left atrium instead in the right atrium instead of the left atrium. So complete mixing is happening in the right atrium, and that's why the whole heart is getting that blood through the ASD. The left atrium gets filled with all this mixed blood, and that's why the left ventricle gets the mixed blood and it goes into the great arteries. Then another lesion like a truncus arteriosus, where you don't have separate pulmonary artery and aorta, you have it like a one trunk, and from that trunk only the pulmonary arteries come out. So there also you will have fully mixed blood, and that's why you'll have low saturations in both upper limb and lower limb. Any region like a detransposition of great arteries, where what is happening is the aorta is coming out from the right ventricle, pulmonary artery from the left ventricle. Now how is the baby surviving? If the deoxygenated blood is going back into the this body, and oxygenated blood is going back into the lungs, so they will have PDA, they will have ASD at birth. PFO every patient has at birth, because the umbilical blood from the mother has to go to the baby's body through the ASD or PFO, which will be present in every child in the womb. Once they are born, it starts closing. So DTJ patients suddenly deteriorate when the PDA starts closing or the ASD starts closing. So at birth, you will see that the saturations are low in all the 4 limbs. And also you see this situation in the persistent pulmonary hypertension of newborn, which is not a cardiac condition, but a lung condition. Second scenario, when you have upper limb saturation which is high, and lower limb saturation which is low. So these are all drug dependent circulations. Let's not go into detail because this will take a lot of time. I just want to emphasize to you that 4 limb saturations and upper limb, lower limb blood pressures is a very, very important clue for diagnosing various congenital heart disease. So this is nutshell. You can take a picture of this one because this gives you all the scenarios wherein the saturations, what scenario, what saturation, and what you're expecting with the blood pressure also difference. Okay. So now I'll move forward. So you have to watch the numbers to catch the clues. A few cases will go to. First is maybe this, I'm not sure whether you get to see children this young, but this is a 1-year-old child with weighing only 5 kilograms. Okay, so it is not grown well, has repeated respiratory infections. So I'm going to take 20 minutes more if you want to come later. Okay. So this father has asthma. And so the child, when it comes to respiratory infections, they are treated with bronchodilators, nebulizations, but it is not getting better. They are feeding fine. On examination, looks okay, non-dysmorphic, but has tachycardia, tachypnea. There are bilateral conducted chest sounds. No significant murmur. But X-ray chest shows this. So this is a big heart, okay? This is cardiomegaly. How do you diagnose cardiomegaly? When you have more than 60% CTR. So normally cardiothoracic ratio is calculated by the maximum diameter on the right plus maximum diameter of the left from the center in a centralized X-ray. So A plus B and C is the diameter of the maximum diameter of the chest wall. So A plus B divided by C. So heart shadow is A plus B. So heart shadow should be 55% at the most of the whole chest cavity in an adult. In a newborn, up to 60% of heart shadow is also considered normal, but anything more than that is cardiomegaly. So here the heart is nearly 70% of the chest wall. So this is a big heart. So now a child with repeated respiratory infection with a big heart, it's a clue. Okay, you should not miss this. This is an X-ray which is very often missed. When you see a big heart, people are not noticing the big heart because they don't. Meaning, what your mind knows, only your eyes can see. So if your mind knows, okay, I have to look for the big heart, only then your eyes will see the big heart. So here, what is the likely diagnosis? Is it a large ventricular septal defect? Is it recurrent bronchiolitis? Is it any airway malformation? Or is it ciliary dyskinesia? Repeated respiratory infections hai, failure to thrive hai bachche ko, and heart is big. So since it's a cardiac forum, we'll go to the answer. It is a VSD. Okay. So why VSD? Because if this patient is failure to thrive because of chronic heart failure. Repeated respiratory infections. Why? Because of pulmonary overcirculation. So what is happening here is through the VSD, there is a left to right shunt. The LV shunting into RV instead of going into the aorta and the body. Okay. So now all this blood plus the right ventricle is receiving its systemic venous return from the SVC, IVC. So this blood and the blood coming from the left ventricle, everything is going into the lungs. So lungs are getting flooded. Now any flooded lung, blood is a very good nutritive medium. So anything which is wet will be immediately infected. Something going through the airway, any virus, any bacteria has good nutritive medium here, it's wetness, so it will grow fast. So you'll get repeated respiratory infection. Why tachycardia? Because you're losing cardiac output. Every contraction, blood is getting wasted into the right ventricle. So less blood is going through the aorta. So how is the body going to compensate? It's going to beat more times. If I need 2 liters to send, I'll have to beat 75 normally. But if I have a shunt which is wasting 5 to 10%, I might have to beat 85, 90 beats per minute to send that kind of blood. So you have tachycardia. Tachypnea again because of the increased blood coming into the lungs. Lungs breathe faster to oxygenate all that. So all this is taking up the energy of the child. There is no calories to spare. Everything what the child is eating is going into the cardiac activity. So the child fails to thrive. Plus there is repeated infection wherein the growth is slowed. So that's how the patient fails to thrive. Why no murmur? VSD should have murmur. When does the murmur occur? Exactly, ma'am. So true. So what happens? Murmur is because of the pressure difference. When your blood froze with the pressure difference, the murmur will occur till there is pressure equalization. There is no flow. Now, there is a big defect, pressure equalization is occurring immediately. So blood stops flowing. But there is same pressure. The right ventricle is receiving and left ventricle are at the same pressure. That's why we are not hearing a murmur. So bigger the VSD, shorter the murmur. Smaller the VSD, longer the murmur. It is paradoxical in VSDs. आपको लंबा murmur सुनाई दे रहा है, छोटा है whole. ठीक है? In case of VSD. Why bilateral conducted sounds is because of pulmonary congestion and X-ray chest is showing cardiomegaly. So here big heart was the clue. I will not go why not repeated bronchiolitis. You can just take a picture if you want. You can read later. So how we ruled out the other differentials is this in the picture. Okay, I'll go ahead. Case 2 now. This is a 7-year-old girl. Oh, why is this moving so fast? So, how do I stop this for a minute? Okay, let me stop here. So 7-year-old girl weighing 28 kilograms complains of easy fatigability, decreased appetite, poor weight gain, occasional vague chest pain, very non-specific complaints. On examination, she looks fine. The chest is clear on auscultation. There is little bit of liver palpable. Initial X-ray is showing mild cardiomegaly, but the lung fields are looking fine. The ECG here is showing left ventricular hypertrophy. Now, actually, to teach ECG right now, but you can in this ECG when we see left ventricular hypertrophy, how we see is the left-sided chest leads. Okay, so we see from V5, V6, you see STT changes. So there is volume overload as well as pressure overload when we see STT changes. So there is left ventricular hypertrophy, and an adult cardiologist had done an echo, and this actually happened 2 weeks ago, and he said that this is a dilated left ventricle with a global left ventricular hypokinesis. So बोला dilated cardiomyopathy है, मुझे drugs के doses बता, ठीक है? That's how he called me. I said, you send the patient across, let me also do an echo and I will give him the doses. So he sent the patient across. So this differential he had put is dilated cardiomyopathy. Viral myocarditis. Now, Al-Kappa and coarctation of aorta are also differentials of a dilated left ventricle. So let me go into the detail of that. So what happened in this patient I showed? So this is the echo when I did in SRCC. This is the left ventricle, okay, in the first picture. So it is very, very dysfunctional. It is dilated. Yeah, let me play it. Mm, okay, it's not playing anymore. But this is a dilated dysfunctional ventricle, and when I did echo, I saw that the right coronary artery is coming from the pulmonary artery. So it was an Al-Kappa. So Al-Kappa is basically what happens is anomalous origin of the left coronary artery from the pulmonary artery. Now what happens is the coronaries are getting filled in diastole, okay? The left ventricle and aortic pressures are high. So coronaries are getting nicely filled in diastole. But pulmonary artery pressures are what left ventricular pressures are. And aortic pressure is like the blood pressure 120/80. So diastolic pressure क्या है 80. Coronaries कब fill हो रहे diastole में. So they are getting filled when the pressure is 80. In pulmonary artery, the mean pressure is 20. Okay, systolic pressure may vary from 30-40. Diastolic pressures may come from 8 to 10. So now the pressures are so low in the pulmonary artery that the coronaries don't get filled properly. So now where is the coronary supplying? The left ventricle. Left ventricle is not getting any blood, so it has got dilated, it has got dysfunctional. So any dilated cardiomyopathy patient, you should look for these correctable causes. These are the correctable causes. Coarctation of aorta. Because of such a pressure overload here, the ventricle keeps on pumping against that stenos segment and then it fails. Then it becomes dilated, it becomes hypertrophied, it becomes dysfunctional. So coarctation of aorta and Al-Kappa are two differentials of dilated cardiomyopathy, which can be diagnosed by an simple echocardiogram. You don't need anything else. Of course, we did a CT because we needed to do surgery. So this child underwent surgery and look at the left ventricular function after surgery. It has become normal. So lesson learned here is that coarctation of aorta and Al-Kappa are some commonly missed causes of cardiac failure, which are indeed fixable. And for children, echo is not just a test, but it's a lifeline and best entrusted to a specialist. So, when adult cardiologists do an echo and pediatric cardiologists do it, it's a vast difference. They are more used to seeing the functional changes. They're more used to seeing the left ventricular motion wall abnormalities, like movement abnormalities, functional abnormalities. But structural abnormalities, they are not very well versed to see. So structural abnormalities, pediatric cardiologists are the best to see. So it's always good to send a patient to a pediatric cardiologist in this case. Of course, many other cardiologists are so good in that as well. But when you're doing something every day, you get used to it. Uh, this is a 12-year-old girl. This scenario, I think many of us must have faced in our OPD. She is brought in the emergency with a seizure-like episode, and this she has got 3 times in the past 6 months. Her patients describe this episode as the child suddenly becomes pale, collapses, followed by 10 to 15 seconds of unresponsiveness. In one instance, she had a brief generalized jerking movement during the episode, and but she spontaneously regains consciousness, feels a little exhausted afterwards. Episodes often occur during physical activity such as running or swimming or during emotional stress, like being startled or scared. So one time when they're distributing papers for her exam, question paper, usko aa gaya wo syncope. Now evaluation. So we go to the evaluation. There's no past significant medical history, but there is a history that her maternal uncle reportedly died at 25 years of age, which was attributed to a car accident. Now we take all these histories very significantly. Any sudden death, maybe because of arrhythmia, maybe because of epilepsy. When you die during accidents, you should always consider in mind some medical problems which are going to cause the accidents. Okay, so if you're getting an epilepsy when you're driving, you will, of course, the car is going to meet with an accident. So we take into consideration these kind of histories when we see for sudden cardiac deaths. Okay. Examination in this girl was normal heart rate, BP, respiratory rate, physical examination was normal, there were no murmurs, and neurodeficit was also not there. Now, we went ahead because she has seizure like history. We went ahead, we did blood test, we did electrolytes, glucose, complete blood count, everything was normal. Then we said we'll do an ECG and EEG. Okay. Now, this was her ECG. I would not expect you to read from this ECG, but I just want you to look at something, that is the T waves. So if you see a ECG, we always see 2 to 3 things. One is we see the PR interval and we see the QT interval. These are two very, very important intervals to diagnose arrhythmias. If you have a short PR interval, you might have a supraventricular tachycardia. If you have a long QT interval, you will have long QT syndrome. Both of these are pro-arrhythmogenic and they can lead to arrhythmias. So in this case, it was a long QT syndrome. So the QT interval normally is 460 in a female, more than 460 we say is abnormal. So here it was 537. And also when you see this T wave alterance, it is a very significant thing. We always want to a defibrillator in this patient because they can have life-threatening arrhythmias. Okay, we have to start them on drugs. We have to give them a. They may also need a implantable defibrillator. If you want to take a picture of the other explanations, why it was not a vasovagal attack, why it was not a Wolff Parkinson White syndrome, it's the answers here. I'll not go into detail for the lack of time. So now, just this one slide, want to summarize. If you see a child with cyanosis, poor feeding, failure to thrive, exercise intolerance, easy fatigability, chest pain, palpitation, unexplained syncope, especially with exertion. Okay, with rest it can be epilepsy, but exertion syncope, always think of cardiac syncopes. And family history of sudden cardiac deaths, family history of a heart lesion, always send this patient for an echocardiogram. So as we said, there's high index of suspicion is required if you have to diagnose a heart disease. See, any patient who collapses can be shock, sepsis, or metabolic problem, but drug-dependent lesions should be thought of. Any patient with long-standing fever may be connective tissue disorder, autoimmune disease, but also infective endocarditis should be thought of. Any patient with recurrent respiratory infections can be allergy, asthma, TB, immune deficiency, but also think about left to right shunting lesions like VSD, ASD, AP window. Any vague abdominal pain can be stomach bug, acute gastroenteritis, parasite, food intolerance, mesenteric lymphadenitis. All these are commonly seen, but always think about heart failure, dilated cardiomyopathy, pericarditis. So these things, if you only think, then you can look for the signs and you can catch those signs. Leg pain, very common, is a growing pain. You usually tell our patients it's growing pain. You give calcium, vitamin D, but feel for the femoral pulses. Look for upper limb, lower limb blood pressures, and rule of coarctation of aorta, because this is also sign of coarctation of aorta. So be vigilant. You're the first line defense, and you play a crucial role in ensuring that children receive the specialized care that they need when they need it the most. I just want to go roughly about what happens to children when they come to the hospital, so that you know when you refer your child what happens to them. So this is our echo room, which is a very child friendly room. We do non-sedated echoes most of the time by playing with the children, giving them toys. And there are various other modalities we have to undertake before the child goes for a surgery. Sometimes we need the transesophageal echocardiography, wherein we put the camera through the esophagus, because we can see the heart very closely from there. There's no skin, soft tissue, bones, shadow coming in the way, and we can diagnose very minute details, like in case of device closures, we can measure the defects. We can see there's fenestrations here. Then this is the epicardial echocardiogram, wherein we do the echocardiogram of the heart in the operation theater before the surgery or after the surgery to see for completion of the surgery. And this is the transesophageal echocardiogram, which has been done again. This is in the operating room after the surgery to see if the surgery is done, if any residual lesions are left, or everything is fine. So that's the transesophageal echocardiogram. Then we need the CT scans. Now CT scan we need when we need to see the structures very well. So sometimes coronaries are not seen very well. The aorta pulmonary collaterals. Sometimes a lot of, like if the child has dextrocardia, situs ambiguous, all these cases, it's best to get there is anomalous pulmonary venous drainage. So the surgeon wants to get a very good idea about what he has to go and do in the operation theater. So those cases we do the CT scans. We have an amazing radiology team, and our scans are actually one of the best which I have seen, even like in all the places where I've worked. So we get like nice three-dimensional imaging, complete 3D overview of the lesion structures, and all measurements are done. We also need cardiac MRIs sometimes when we need to see the function. So when people have single ventricle conditions, then we do MRI just to see the LV volume. Sometimes in case of tetralogy of fallow repair, there is the transanthular patch surgery is done. That means what happens? The pulmonary valve is cut open and a patch is put to increase the right ventricular outflow, to increase the space for the blood to go. But then the valve starts leaking. Now, because of the leakage, the right ventricle starts getting bigger. It starts getting enlarged. So we cannot let it enlarge indefinitely. We have to put a pulmonary valve in that place. But the best timing to put the valve, we do the MRI to see the volumes. And there are cutoff volumes wherein we decide that we have to go ahead and do the pulmonary valve placement. Also, we see MRIs in case of these cardiomyopathies, because sometimes some causes are reversible causes. We can see the muscle morphology, like fibrosis there, is there any kind of degeneration, all that through the MRI. Genetic test is another thing which we all rely on, because congenital heart disease, we all know there's a lot of genetic correlation, like in Down syndrome, we have congenital heart. There's a lot of syndromes which have associated with it. Fetal echo, I want to emphasize this very to all of you, that it's such a great tool, because you are mentally and physically prepared to receive the child with a heart problem, where to deliver the child, for the best treatment optimal. Not all children with a heart problem need to be delivered in a peripheral center. Many of the children can be delivered wherever they have to be delivered, and echocardiogram can be done on the day one, provided we have done a good fetal echo and we know what lesion we are dealing with. Drug dependent lesions, of course, you need to deliver them in a peripheral tertiary care center where the cardiac facilities are available, because immediately we need to start on prostaglandin so that the drugs don't close, and then we can go ahead for surgery. So these are few indications where fetal echo is absolutely required. And nowadays, what happens with IVF pregnancies, advanced maternal age, the fetal echo becomes more and more important, because the chances of congenital heart disease are very high. Another thing, just on the other side of the spectrum, is that even minor lesions are getting aborted, because our scans are not done by cardiologists, they are done by radiologists. And radiologists are not abreast with what we can actually do to children right now. So many cardiac conditions are beautifully treated and have near normal life, but still those people don't know about it. And that's why they ask, no, heart problem hai to aapko better hai ki abort karo. So it happens so much so that even simple VSDs are getting aborted, which they actually need not. Okay, so I want you to also understand that part, that any cardiac problem, better to consult a cardiologist, because we know what is actually the prognosis, the timing of surgery, where to deliver, and etc. Pediatric cardiologist, definitely. Yes. uh, yeah, so I will not go into the details of fetal echo. We do Holter monitoring to, again, for all the rhythm problems of the children. It's a stress testing is done for in case of mostly syncope. So this is a story of a New Zealand child, but I don't want to go in detail. This is a tilt table test, again, for various diagnosis of various syncopes. We can diagnose neurocardiogenic syncopes, vasovagal syncope, then POTS, that is paroxysmal orthostatic tachycardia syndrome. So all these dizziness and syncopes can be diagnosed with the tilt table test. Then we do cardiac catheterizations. Again, it is diagnostic and therapeutic. Diagnostic is to measure the pressures to see if the patient is operable or not. And therapeutic is we do device closures. So this is a device closure procedure. I will show you my cath lab. Yeah, if these videos play. So they are not playing. So this is basically a cath lab table. I'm operating on the table. We have a CM. We have a biplane cath lab, which is the only biplane cath lab in the whole of the city. No other pediatric cardiology center has a biplane cath lab. It increases the precision of procedures. You know how we can see it from both the sides, 360-degree view. And we do all sorts of interventions. PDA stenting is like the highest level intervention, which we have done a big program of, and we have published papers, and I go for talks about this in various centers. If these are not playing, then it's really not worth the time. Yeah, it's playing finally. So just a device closure procedure. I'm doing a femoral artery and femoral vein puncture to access the heart. Now we go through the femoral artery. for the left-sided lesions. And usually all the device procedures are done through the venous approach because we don't want to disturb the artery with a large size sheath. So sheaths take the devices up. So now this is the arterial puncture done. So this is a PDA device closure procedure. So after the sheath support, it's like when you put an IV line, no, you remove the dilator, same thing, and then we have the side port through which we can do injections, we can measure the pressures. Yeah, so now in this picture you can see the device. So that's the devices are of different shapes and sizes depending upon the lesions. And they are made of nitinol, which is a alloy and which is actually inert. So you can it is MRI compatible, electrophysiology compatible, everything, and it becomes a part of the heart. And utilizes within 6 months, you have to actually dig it out from the heart. So it basically is a meshwork wherein the clot forms, and that works with the principle of memory. So you can actually pull it in a cylinder, and when it push it out, it will again have the shape memory. So if you see this device, now I'm going to take it into my introducer. See how it just becomes a you can slenderize it, and then when it goes into the body, again we push it out and it becomes the same shape. So this is just loading. For loading, we screw the device on a cable which has a screw end, and when it goes into the body, we unscrew it. So this is how I'm taking it inside. We do it all underwater because we don't need air in the system. Then we are introducing the device into the sheath. So it is going into the sheath. Now we can see it is going into the body. That now my route is I've gone from the right femoral vein into the RV, pulmonary artery, and then I've crossed the pulmonary artery and went into the PDA, and from that I've gone into the aorta. Then I'm going to deploy the device across the PDA. So that now I'm deploying the device. So this is here. I'm going to, this is the device, and then I'll unscrew it to release it. It's a 2.0 kg child whose device would be done from 500 grams PDA ligations to the biggest of the structural heart disease we treat here. I'm just doing done. So surgery, see how the patient goes to the surgical theater. They go on these like nice cars. They're very happy when they go to the theater. And this is the operation theater. The cardiac theater has lots of machines. You have a perfusion pump. You have a lot of doctors, technicians. So this is a whole team which you require to actually take a baby from the operation theater to the finally when the baby goes out. So you have this a team of cardiologists, cardiac anesthetists, perfusionists, technicians, radiologists, everybody all together help in the it's a team work actually. No single person can actually do it fully. So thank you for your patience hearing. If there is anything, any questions, I'm happy to answer. Over to you, Sonal. Thank you for waiting. So Sonal is our pediatric radiologist. She will be doing the next one.
Good afternoon, everyone. Our next speaker is Dr. Sonal. Dr. Sonal is a consultant radiologist, full-time with SRCC Children's Hospital. She will be talking about imaging in pediatrics. I welcome Dr. Sonal.
So for all these multi specialties that we have at our hospital, you need very robust diagnostic services. And that backbone of all this work is formed by pathology and radiology. So I will now quickly take you through why do we have this subspecialty of pediatric radiology, how is it different from general or adult radiology, and why we need that imaging focus. And if you all have any questions, you all can ask along the way. We can make it interactive. Okay, so pediatric imaging is definitely indispensable to a better outcome in pediatric patients, whatever be the underlying pathology. So, why do we need a pediatric radiologist? Why isn't a general radiologist good enough? What is the scope of radiology services in pediatric diagnosis and treatment? Understanding the different modalities and which one do we need when. Very often we get a prescription asking for a particular imaging modality, but when we dig into what is the clinical suspicion, we understand that no, this will not help. So, what is it that will really help? Then, for a lot of the radiological investigations, we do need sedation because they are children, they may not cooperate. So, what are our sedation guidelines? When and why do we need contrast imaging? When do we need to give intravenous contrast? Some common clinical scenarios and what is to be done. And now radiology has advanced at a very rapid pace. So, what are all these new techniques that we have? Are they really useful, or are they just fancy imaging techniques which don't have any clinical relevance? So in radiology, we know there is two subgroups of imaging modalities, those that have ionizing radiation like plain X-ray, fluoroscopy, CT scan, and all your nuclear medicine tests. And then you have the non-ionizing radiations like ultrasound, Doppler, and MRI. And that second group of non-ionizing radiation forms the mainstay for pediatrics because it is safe, because it doesn't have radiation. So the fundamentals of pediatric radiology are that the first fundamental rule is to image safely. You want to give the children as little radiation dose as possible. Weigh the pros and cons of doing that imaging modality. Like in adults, without thinking, we ask for HRCT, chest, CT, abdomen, X-rays, etc. But in children, we really have to think that is this really required and is it going to help in diagnosis? Secondly, we need to have a very clear idea. In adults, anybody comes and says, I have a chest pain, I have an abdominal pain. Without putting too much thought into it, we ask for investigations. But with children, we really need to know, okay, what is it that we are suspecting and how can we find out and what is the relevant imaging modality? And when we don't know, okay, lots of times we don't know. So let's discuss. Call us up. We would also like to have a word with the referring clinician that this is what the patient has, this is what I'm suspecting, and how do we proceed. So let's discuss. Let's keep the channel of communication open. And this fear of contrast reaction, to give you all the latest update, that the latest contrast that are available in the market, the non-ionic contrast agents, have for some reason been found to be very safe in children. We have barely seen any contrast reactions in children. So the contrary is true. Now, just as they showed you how friendly our imaging services are, similarly, we have very friendly environment in our imaging services. Our technicians have become pros at getting the children to cooperate without moving. So the plain radiograph, which is the first imaging modality, you always need it for extremities, you need it for abdomen, you need it for chest. Now, the main thing is that, again, we should know what we are looking for. And secondly, if the child has had any previous radiograph, it is always useful to compare. As we know, certain organs like the thymus, which shrink in size as the child grows, Other organs increase in size as the child grows. So we need to be able to compare that. Now, this is the chart of the radiation dose that is administered roughly, and the maximal permissible dose is only 1 to 2 millisievert. So again, we have to be very careful when we are suggesting investigations and make sure we are doing the right investigation, so that that radiation dose that you are giving to the child has to be justified, that why are we giving this radiation dose. Okay, the next imaging modality that we have is fluoroscopy, where we can do an upper GI series, lower GI series, barium meals, follow throughs. Now, again, barium is very safe for the GI tract of the child. Even if he aspirates it into the lungs, even if he vomits, he'll pass it out in his stool. Barium is completely inert, it is safe. However, if we are suspecting a leak post-surgery, like a tracheoesophageal fistula or an esophageal atresia, or anywhere where there is a leak, then we prefer gastrographin. So again, that clinical information is very important, that what are we looking for and what are we expecting. Now, this is the latest generation of video fluoroscopy that we have, where real time we can see the entire swallowing mechanism, and lot of children with neurological issues, where you want to see whether there is an oropalatal dysphagia, whether the dysphagia is lower down, whether there is a reflux, whether there is an esophageal dysmotility. All this can be beautifully seen on video fluoroscopy in two shoots, one in the central and one in the lateral, and you can examine the entire orodigestive tract. So this is really a great, and we have one of the latest generation of fluoroscopes. And this is a small example of a 40-day male baby with repeated chest infections. And you can see here the reflux going into the lower esophagus. Now, for genitourinary also, you know that we have voiding, micturating VCUG or MCUG. There is retrograde urethrogram and genitograms, and all of them have their own indications. So again, just to show you a case, you can see them voiding real time. And this is a 6-year-old child with repeated urine infections. And you can see he has a hugely dilated posterior urethra. So he had posterior urethral valves. So, this is something that is like unmissable. You see the video, you can diagnose it, you can repeat seeing it, you can review it later. It is great for the child also to have in his records. So now from static films, we have moved to these videos. Okay, and children videos are very helpful. As you know, sometimes they will urinate, sometimes they will not, sometimes they will swallow, sometimes they will not. So if you have the video, you have the entire record. Okay, next we move to ultrasound. As you know, it is really a robust modality for children because it can be performed bedside. You can do almost head to toe, all body parts can be imaged. It has no ionizing radiation, so it is completely safe and non-invasive. You can subject that child to ultrasound even 100 times a year and there is absolutely no problem. In addition, you can use it to do certain image-guided interventions, like children with lymphangiomas or hygromas, we give them sclerotherapy. Children with masses, we do ultrasound-guided biopsies or pigtail insertions and abscesses. So it is a very robust modality. However, the number one limitation is that it is observer-dependent. So if that person is not tuned to doing a good pediatric ultrasound and is not tuned to picking up pediatric pathologies, you probably will miss it. And very small children, for Dopplers, they may need sedation in the form of pedicloral is what we give, which is just the oral sedation. They don't need any intravenous sedation. Now, again, for preparation, as we know, the child needs to have had water. Moving on to some interesting cases. This was a 3-year-old child with a swelling in the neck, which was gradually increasing. Now, I know outside, the first investigation a lot of people will ask for is a CT scan or an MRI. But here, ultrasound showed that this was nothing but a lymphangioma. And we gave bleomycin injection under ultrasound guidance, and it resolved and the child is doing very well. Similarly, this is a second child. It's a 2-year-old female with a soft tissue swelling and discoloration over the left eyelid. And the clinician suspected a vascular tumor and he asked for an MRI. Okay, but we first went ahead with the sonography, and here you can see this leash of vessels. And this was nothing but an infantile hemangioma. Now, the only indication for MRI over here would be if you want to look for any intracranial extension or if the child has lesions elsewhere. But you can start with a very simple bedside imaging modality, which is an ultrasound. This is another 3-year-old who had cough and fever with elevated counts and loss of appetite. Now, of course, there is a pneumonia, but in addition to that, the basic thing we learned in MBBS, there is a blunting of the costophrenic and the cardiophrenic angle. And you know that somewhere there is a pleural effusion. But this doesn't have the meniscus sign of the fluid. In fact, the effusion is looking a bit complex. And the child was not settling with antibiotics. So in children, the second possibility of an empyema is very, very common. So we did an ultrasound of the chest, which again is something that most people would not do. And here you can see that there is a collapse of the lung, but you can also see that there is this large honeycomb type of cystic lesion in the pleural space, and this is nothing but an empyema. And ideally, you don't even need a CT chest for this. And why do we want to know that there is an empyema? Because this child is not going to respond to antibiotics. He is going to need a thoracoscopic decortication. Okay, so but the CT chest was still done by the surgeon, and here you can see that there is a necrotizing pneumonia and a complex pleural collection. So ultrasound chest is also a very robust modality. As you know, you can use it even for pleural fluid tapping, etc. Now, this is another child who is a 3-year-old child with a painful limp over the right hip joint, and you can see that there is some widening of the joint space as compared to the opposite side, and there is a displacement of the muscular fat planes. Now, a very simple X-ray, you can pick up these findings, and this is the frog leg view. And again, a very simple bedside modality like ultrasound can show that there is a collection within the hip joint space, which is showing debris and echoes. So this is definitely a synovitis or a septic arthritis. And then you can correlate with your blood counts, etc. So again, for ultrasound and joints, no preparation is required. We use it very commonly to screen for developmental dysplastic hips in babies, but you can also use it in older children to look for synovial thickening, joint effusions, septic arthritis, etc. Now, coming to cross-sectional imaging, of course, in our institute, we have CT scan and MRI, and for PET CTs and other scans, we send them outside. Now, very often we are able to get the children who are over 6 years of age to cooperate without sedation, give them a lot of vocal anesthesia, a lot of talk through. We have gadgets to show them how the MRI and CT scan is done. But some children still don't cooperate, and then unfortunately in them sedation is required. So this is the International American Anesthesia Guidelines, where we have the 642 regimen for sedation for fasting. And I know a lot of people get perturbed that why 6 hours of fasting for such a small child, but that is only for children who are not on breast milk. The ones who are on breast milk, 4 hours is enough. And then and the other thing I want to highlight is that up to 2 hours the child can have a clear fluid like an appy or water or juice or sugar water or ORS, so that there is no dehydration. He cannot only have solid food. Okay, and because we have been implementing this rule, we have had almost no aspiration pneumonias and no adverse reactions because of the sedation. Okay, so this is the CT scan now, which we have the really developed multi-detector CT scans. We also have the HR CT scan where we use very thin slices to see what is the pathology, and there is no additional radiation in that. So that is something to be noted, no additional radiation. Okay, so now this is the HRCT scan of the chest where you can see the minutest details like the interstitium of the lung when you do the HRCT. And similarly, this is an HRCT of the PNS where you can see the minutest details of the bone erosions, the bone linings, etc. So we have now moved on to high resolution CTs. Okay, so sometimes we need contrast, sometimes we don't need contrast. Let us decide that. But what we do need is a serum creatinine if the contrast is to be given, and that is completely non-negotiable. In fact, children have more immature kidneys than adults also. So we have to ensure that the serum creatinine is normal. before we proceed with a contrast examination. Okay, this is when contrast is needed, like in infection, in tumors, when you want to do an angiogram, when you are suspecting an AV malformation or an aneurysm, and in some way contrast is not needed. So again, if we know what we are looking for, we can tailor the investigation for that particular patient. Okay, now this is the next imaging that we have, which is MRI. Okay, now few myths from before, which I would like to clarify, that the new generation of pacemakers have now become compatible with MRI. The only thing that is still not compatible are cochlear implants in children. They definitely cannot undergo MRI. And even in metallic orthopedic implants, the latest generation of orthopedic implants are all safe for MRI, and usually after 6 weeks, we are absolutely not worried that they will move or they will get magnetized in the field of magnetization. So the only absolute contraindication is a cochlear implant, or if the child is not suitable for sedation and he is moving too much and you're not getting good pictures. Okay, and again, if we are going to give contrast, then an EGFR less than 30 is a definite no-no. So as you know, the pros of MRI, in addition to ultrasound, Doppler and MRI comes as the third most robust modality because there is no radiation. You can image all the parts of the body. We are able to do angiographies in MRI without contrast. So that is also a huge advantage. If a child has a high creatinine, we can still do the angiography without contrast, and there is no radiation. So again, these are the indications when contrast is needed and when contrast is not needed. Now, for angiograms and venograms, as we know, we can use CT or MRI. MRI you can do without contrast. CT you always need contrast. Now, I'm just going to run you through the latest revolutionary methods of diagnosis that we have in our current generation of machines. And what I want to highlight is, are these just fancy products that are available in a supermarket, or are they actually having any benefit? So to give you an example, this was a 9-year-old boy who had a left facial clonic seizure and on and off headache since a year. And the MRI showed that there was this lesion in the right cerebral hemisphere, supratentorial region, which was obviously a tumor. Now, in brain tumors, I think the role of a radiologist, besides telling you the site, size, location, etc., is to give you the idea whether this is a high-grade tumor or a low-grade tumor. And for that is when all these fancy imaging techniques come into play, like perfusion and spectroscopy. And on the basis of these findings, we diagnose this as a low-grade glioma. And that helps because then the surgeon can go and attempt a complete resection immediately without having to give any radiation or chemo or anything in advance. So this is our first MR indication of MR spectroscopy for tumors, infections, mitochondrial disorders, etc. It can be done in conjunction with the MRI at the same time. Now, this is another example of a 4-year-old girl who was a known case of aqueductal stenosis, and she underwent a third ventricular stomy. But in spite of that, she was complaining of persistent headache and intermittent vomiting. So the surgeon really wanted to know what is happening with the CSF flow dynamics. So this is what we call as the CSF flow metry. And you can see here that there is a reverse flow across the third and fourth ventricle. So there is some obstruction to the drainage of the CSF. And this helps them to plan the further management. So these are all the indications of an MRI CSF study. Okay, then this is another example of an 8-year-old child who presented with right shoulder and right hip pain. And as we started seeing the shoulder, we saw this lesion, which made us suspect a very new condition known as CNO, also which is called as chronic non-infectious osteomyelitis, which has become far more common in children than we knew. It is an entity that was only described about 10-15 years ago. And for that to be diagnosed correctly, you need to do a whole body MRI. So when the child is under sedation and you pick up something for which you have to extend your scan or change your scan, you can only do it if you know what that condition is or what we are looking for. So this is a whole body MRI. And in addition to CNO, we also do it for marrow imaging like infiltrative disorders, etc. Now, this is a 7-year-old child with thalassemia who is posted to undergo a bone marrow transplant. So, this is something known as iron quantification, which we do in different parts of the body, also known as T2 star imaging. And this is another very fancy thing that we have here, which is the cardiac MRI. It's not only fancy, but it has a lot of robust indications and diagnostic potential, where you can real time see the cardiac and the extracardiac structures. Okay, so this is cardiac MRI. You can see the ventricular walls, their contractility. You can see reflux. You can see myocarditis, is the myocardium enhancing, etc. So cardiac MRI, which is excellent even for scarring and viability assessment and pericardial diseases. Okay, now the next thing that we have is MR perfusion for the hip joints. So this is a 9-year-old boy with a painful limp, and you can see that there is a small sized femoral epiphysis. Now everybody knows that this is an avascular necrosis. So why subject the child for any further imaging? And the reason is this, because when you do a perfusion, it gives the orthopedic surgeon the exact location of the poorly perfused sites and where he needs to go in and do his drilling to improve the blood flow to that hip. Similarly, this is a child of Perthes disease. Again, when we do the perfusion, you know exactly which pillar, the anterior pillar, the lateral pillar, which pillar has the least perfusion, and that helps guide management. Now, another fancy imaging technique that we have is DTI. So this is a child with a focal cortical dysplasia. And here you can do a tractography where all the white matter tracts which we had learned can actually be imaged and visualized. So when you are going in for surgery, you can tell the parents that, look, this tract will be sacrificed. The child may lose XYZ function, which will help them be prepared as well. So this was the preoperative imaging, and postoperative, you can see there is a complete excision of the lesion. But on tractography, what you can also see is that the posterior fibers of the corticospinal tract have got disconnected, unfortunately. So this is what we call as diffusion tensor imaging and fiber tractography. And this is the last case that I will show, which is a 3-year-old child who had chicken pox and later on presented with left-sided focal seizures. And here you can see that he has an infarct in the right basal ganglia. And when we do the angiogram, you can not only say that this is stroke, but what is the etiology of the stroke? And that is a cerebral arteriopathy. So this is vessel wall imaging, which gives you both the lesion and the etiology. So this is dissection. Okay, and the last, absolute last case I will talk about is fetal MRI, which has also now become a very upcoming modality. So this is a patient who was diagnosed as borderline colpocephaly. Now we all know that ventriculomegaly, there is almost an incidence of 0.01% of scans that we do. And this was very borderline, and fetal MRI was suggested. And here you can see that there is an agenesis of the corpus callosum. So fetal MRI is absolutely non-invasive, safe. There has been a landmark change with the extension of the MPP Act, which has now moved to 24 weeks instead of the previous 20 weeks. So you get that extra 4 weeks to make an educated choice as to whether you want to continue the pregnancy or not. And this is functional MRI and MR elastography. So just to summarize, that children are not little adults. We need to move on to safer imaging modalities in pediatrics. You need to have the multidisciplinary approach like we have in our institute with pediatric anesthesia on board, all our surgeons, all our clinicians. Interpretation also requires expertise, clinical integration to guide the management and teamwork. And these are all the various teams we have in our hospital. With that, I will end. Thank you very much. And if there are any questions, I can take it. So for most MRIs, because an MRI is a lengthy examination, it is almost 40 to 45 minutes. Sometimes adults cannot cooperate for MRI, so it's obviously not practical to expect children to cooperate. Having said that, some older children are able to cooperate. We keep the parent inside with them and they can cooperate. But again, the older children who are mentally challenged or they have IQ issues, they will not cooperate. So that we decide on a case by case basis. Is this child going to cooperate? We always like to give a trial that if they cooperate, great. If they don't, we will need sedation. Again, CT scans in small children when we are going to give IV contrast, because the minute the IV contrast goes into the veins, it causes them little pain, little discomfort, then they move. So we prefer sedation for that. If it is a plain chest, plain PNS, or a plain non-contrast scan, usually we get through with it without sedation, unless it's a baby, because the baby is not going to sit still. Ultrasounds, most of the time we don't need sedation, again, unless it is a Doppler, which is slightly lengthy and the child needs to be still, then, but for that we are very comfortable with pedicloral, which is just the oral sedation. X-rays and fluoroscopy, of course, there's absolutely no sedation. Even in a neonate, we do it without, I mean, there's no sedation required. No.
So I'd like to invite Dr. Rasik Shah, sir. He is a senior pediatric surgeon at SRCC Children's Hospital and also the in charge of this monthly masterclass.
Thank you, Rujun, for coordinating these activities for last so many years. I was supposed to give a talk on abdominal pain, but that talk will take 45 minutes, and I don't think everybody will like to hear that now at almost 5 o'clock. So I'll just tell in general, first of all, thank you all for coming over here and attending online, so many people. So as a pediatric surgeon in this particular hospital, we do almost everything, all system we operate. Our core area of strength includes minimal access pediatric surgery, which we do almost from newborn to older child in newborn T fistula, duodenal atresia, and diaphragmatic hernias, pull-throughs. All this we can do laparoscopically. Advanced urological surgery, pyeloplasty, re-implant, we do it laparoscopically. We do even tumors. We have very robust hemat-onco department. Along with that, all kind of tumors we take care. Antenatally detected anomalies, we can take care of them postnatally. Some intervention even antenatally can be carried out in indicated patients. The advantage of delivering mother who has high-risk fetus, the advantage of this place includes we have very good NICU. Our anesthetists are pediatric trained, which may not be easily available everywhere. And we have pediatric surgeon, pediatric cardiac surgeon, neurosurgeon, whatever the anomalies are there. So anything in pediatric surgery, we can take care of them in this particular hospital. This particular topic which I was supposed to speak on today was abdominal pain, but because we had another 4 speakers and the talk has exceeded the time, so we will do it probably in the month of October, November. And it is a good topic with multiple videos. I had taken earlier also, but that was I think 3-4 years back, and it would be interesting. And I thank Midtown Association, the general practitioners from Midtown Association to come over here and attend this particular program. We look forward to your association even in future. And as all of you know that we can take care of children with any anomalies, anything. So do remember us whenever you need. Thank you everybody. Thank you, sir. Nice to see you all. बिल्कुल तो पहले से in fact my first talk in Mumbai was with Mehta 1999. I spoke on Ashwin and Anil. You were new looking, sir. So you got a pushpa. The human that is that register. Attachment.